Hi, good afternoon everyone. I'd like to welcome you to my talk on the efficacy of SLT for angle closure glaucoma. So I've received research support as well as travel support from Alex before. So as you know, in glaucoma, there's two main forms of glaucoma: open angle and closed angle glaucoma. And angle closure glaucoma is an important cause of glaucoma worldwide, especially in Asia. It affects more than 30 million people. It's also a form of glaucoma that causes a lot of blindness in the world. The conventional management of angle closure glaucoma involves doing a laser iridotomy as the first line of treatment. This is the reason why we do a laser iridotomy, is to relieve the pupil block that's present in the condition. As you can see in this picture, a patient with angle closure with pupil block marked by a convex iris configuration. And after the laser iridotomy, the iris is flatter and you can see that the angle has opened up. However, we know that if we do a laser iridotomy for patients with chronic angle closure glaucoma, many patients require further medical treatment. For example, 90% may require medical treatment and 50% may require surgery. So what about SLT for angle closure glaucoma? We know that SLT is a safe and effective treatment for open angle glaucoma because it targets the pigmented cells in the trabecular meshwork with no collateral damage to the underlying structure. And SLT may also be a treatment option for angle closure patients in whom the angle has widened following laser iridotomy, and so that you can see the trabecular meshwork to apply the SLT shots. Here's an example of a patient with angle closure glaucoma. As you can see in the picture on the left, he has no angle structures visible. However, after laser iridotomy, you can see that some angle structures become visible, and this you can see the trabecular meshwork within this picture, and this is where you can perform SLT in the part of the angle in which is open. So back in 2009, a multicenter study was performed for SLT for angle closure glaucoma. There were 4 countries involved in this study, and they looked at 65 patients with 65 eyes. Every patient had post-laser iridotomy for at least 1 month, and they had high pressure after the iridotomy. In every patient, the trabecular meshwork must be visible for at least 90 degrees, and they treated an extent of about a mean of 170 degrees with a mean of 56 shots. And the medications were kept the same throughout the study. So in this preliminary study, they found that SLT could reduce the IOP from a mean of 24 to a mean of 19 milliliters of mercury after 6 months. And this was quite a significant drop in IOP, although the medications remained the same. Based on this data, in Singapore, we performed a randomized prospective controlled trial comparing SLT versus prostaglandin analogs, in this case Travatan. We also recruited 2 other centers from Jakarta and Hong Kong. So the aim of this study was to determine if SLT is an effective treatment for lowering IOP in patients with chronic angle closure over 6 months. So we recruited patients who have angle closure of at least 180 degrees before the laser iridotomy. But after the laser iridotomy, the angle had opened up and you had at least 180 degrees in which the posterior trabecular meshwork was visible. IOP had to be high of between 21 to 30 milliliters of mercury. We excluded people with secondary angle closure as well as people with advanced glaucoma, such as those with cup-to-slit ratio of more than 0.9 or visual fields involving the central 10 degrees. This is a study protocol with follow-up visits at 1 week, 4 weeks, 3 months, and 6 months. At every visit, IOP was measured by a Goldmann ablation tonometry. And for the baseline and month 6 visits, we also took IOP at 9 a.m., 1 p.m., and 5 p.m. And the mean IOP was taken for analysis. So patients were randomized to either SLT or prostaglandin analogs, in this case Travatan, given at night. Pre-SLT, we gave a drop of brimonidine and pilocarpine, and the SLT was delivered via the Latina lens. The laser power started at 0.6 and increased to 0.1 millijoule steps until you saw the champagne-like bubbles. And we performed approximately 100 to 150 non-overlapping shots over at least 180 degrees of the angle. And patients who had post-laser IOP spikes of more than 5 millimeters of mercury were treated with oral acetazolamide. All patients were given prednisolone acetate 4 times a day for 1 week. And if the pressure was still high at either the week 4 or month 3 visit, we allowed one retreatment with SLT if there was a less than 20% reduction of IOP. We also allowed treatment modification for safety reasons if the IOP became uncontrolled. So for this treatment, additional treatments were allowed were timolol first, followed by dorzolamide, and followed by brimonidine. The primary outcome was a change in IOP from baseline to 6 months, and the secondary outcome was a proportion of patients who had IOP less than 21, as well as those who had more than 20% IOP reduction. So I'll present to you the preliminary results of the Singapore cases only. So in the 60 randomized patients, we had 30 in the SLT group and 30 in the prostaglandin group. This table summarizes the baseline characteristics of the patients. The mean age was similar, as well as the proportion of males and females. The baseline IOP was also similar, 23 in the SLT group and 22.4 in the prostaglandin group. And the extent of PAS was also similar. And most of the patients had PAC, and there was some PACG in both groups, with a mean cup-dish ratio of 0.6 in both arms. The mean MD is also about minus 4.5 and minus 3.8. So the mean area of SLT treatment was at least around 329 degrees, and the mean energy was 100 millijoules. We did an average of 128 laser shots, and some patients, 7 out of 30 in the SLT group, required a repeat laser. So this is about 23% which required a repeat laser. This table summarizes the IOP response at 6 months. As you can see, the mean change in IOP was 4.8 millimeters of mercury, or 20% in the SLT group, and similar 4.1 or 18% in the prostaglandin group. So really there was almost an identical response, if not even slightly better response in the SLT group compared to that of travotan. If you break up the success rates by complete and qualified success, you can see that there was a 76% complete success in the SLT group and 16% in the qualified success in the SLT group. And this was comparable to that of the prostaglandin group. So this shows an overall a very good and satisfactory IOP reduction in the SLT group. In terms of the patients who had more than 20% reduction from baseline, 50% had more than 20% reduction, and 13% had more than 30% reduction. And this was slightly better than the prostaglandin group of 36% who had more than 20% reduction. And here this table summarizes the patients who had complete success only. And you can see here that the mean IOP reduction was 5 millimeters of mercury, and the mean percentage reduction was 21.7%. Some patients in the SLT group required additional medications. As I said earlier, 5 out of 30 or 16% were qualified successes and required additional medication. But the mean number of medications was only 0.33. And only one patient had an IOP spike of more than 5 millimeters of mercury, and this was satisfactorily treated with acetazolamide. There were no other complications in both arms of the study, and no patient had to require trabeculectomy or any other surgery. So this is the first randomized controlled trial to evaluate the efficacy of SLT in patients with primary angle closure or primary angle closure glaucoma. As I mentioned earlier, in a previous study, SLT achieved a reduction of more than 20% when used as an adjunct to existing medications. In this study, there was no adjunct treatment, but it was a primary treatment. And we found similar efficacy to prostaglandin analogs in terms of mean IOP reduction, percentage IOP reduction, success rates, as well as the number of patients who required additional treatments. So these were eyes in which the angle had opened up after LPI. So you have to remember that you cannot perform SLT for all patients with angle closure glaucoma. For example, those in which the angles are still closed you will not be able to perform this SLT treatment. It exists only for those in which the angle is widened sufficiently for you to see the trabecular meshwork in order to perform the SLT. We also excluded cases which were severe cases of ankle closure glaucoma, and these cases probably would require trabeculectomy. We also found a very good safety profile. There were no significant side effects from the SLT, and only one patient had an IOP spike of more than 5 millimeters of mercury. Of course, the low rate of IOP spikes could be due to our use of preoperative brimonidine as well as pilocarpine. We believe that if found effective in the long term, SLT may help overcome the barriers of compliance, cost, side effects, and quality of life associated with chronic medical therapy. And definitely it's an alternative to medical therapy in ankle closure patients in which there's elevated IOP after a laser iridotomy. Of course, we know we need further studies to establish the long-term efficacy and safety of SLT in ankle closure. There were some limitations of this study. Firstly, the follow-up period was only 6 months. We allowed a retreatment of SLT, so 16% of patients were allowed to have a retreatment with SLT or one retreatment. The study was a short term, so we don't know the long-term efficacy. And finally, there's not a double mass study. So in summary, SLT appears to be an effective modality of IOP reduction in eyes with angle closure or PACG after LPI, at least for 6 months. The mean IOP reduction, percentage IOP reduction was similar to the prostaglandin therapy at 6 months, as well as was the complete and qualified success rates in both arms of the study. 23 patients of the SLT group required a repeat laser. There were no serious sequelae associated with laser therapy, such as uncontrolled IOP or progression of peripheral anterior synechiae. So I believe that SLT is an attractive option for you, if your patients who have angle closure after LPI in which the angle has opened up. I'd like to acknowledge my study team, as well as my collaborators in Jakarta and the Chinese University of Hong Kong, and grant funding from Alex. Thank you for your attention.